All right, well, I appreciate this opportunity to speak with you about bariatric surgery. Let me go ahead and start off by saying this, that we're here to help you. For those patients who have failed diet, exercise, and behavior modification, for those patients, we would like to see them and to help you assist the patient achieve better health. So last year, we introduced the concept of bariatric surgery here at the Heart Hospital. I was in Louisiana for 7.5 years and set up a bariatric practice down there, and they recruited me up here to come and start one. And so we started with a vision of preventing heart disease, and there's two people in particular that I want to pull out by name, Katie Hill and Amy Zell. These two have been working since before the BMI Institute was even there, and so they've been talking to you. That's exactly right. They've been going around and visiting you, they've been talking to you, they've been setting things up, and so, even back in July and August of last year, they've been working and doing just a tremendous amount to get everything set up to make things as smooth as possible. So, a lot of appreciation for them and for their work. So since January 18th of 2017, that's when we started the program, we have seen approximately 312 new patients. We don't know how many of those are going to translate into surgeries. Anecdotally, from my practice in Louisiana and also from talking to some of my other colleagues, probably 150 to 250 of those will turn into cases. Average age about 52, 47.7 is our average BMI. You can see our surgical volume and how it's just going up tremendously. We actually did our first case within our first 30 days. August, we're projecting to do about 30 cases during the month, give or take. Just to give you an idea of kind of the volume that we're seeing, an average bariatric surgeon does about 125 cases a year, which translates into about 10 cases a month. A busy one does about 150, and so we're already double of what a busy bariatric practice would have, and we're only 6-7 months into this. So our volume has been going up just exponentially. The red line is the sleeves, the black line is the bypasses, the gray line would be revisional surgeries, taking out bands, bands to sleeves, whatever. Obviously, sleeves are far and away what we do the most of. Since that time and through July, we've done about 62 cases. 82% of them have been sleeves, 10% bypasses, 8% were revisional cases. Our length of stay of the 51 sleeves, 48 of them went home the next day, which is what you would expect. And then 3 of them ended up staying beyond the first day. 2 of them went home post-op day number 2. They had a little issue getting down enough fluid, and so they stayed 1 extra day, went home and did fine. 6 bypasses, you expect them to go home on postoperative day number 2, and all 6 of them went home on postoperative day number 2. Complications, you can't cut hair without having complications, and so major surgery is no different. Our complication rate, based on how you would traditionally measure complication rates, is about 3%. National averages, sleeves about 5 to 6%, bypasses about 8 to 9%. And so our complication rate is very, very low. Both of the complications that we had to do with a rebleed after surgery. One of the patients, we found it in the hospital, went back to surgery, but they went home post-op day 2 and they're doing well. Second one was kind of interesting. They actually went home on their regular post-op day 1. We saw them at their 2-week check and they were doing fine. And then about day 16 or 17 out from surgery, I got a call from Louisiana, and that's where the patient was from, and they said that they were bleeding. So we brought them up here. Sure enough, they were, took them back to surgery. Here we are 16, 17 days out from surgery. Pretty abnormal, but they were on Plavix and aspirin for a variety of issues. So we also have enough data to talk a little bit about the cohort of patients that we've seen in follow-up over about a 6 to 8 week period of time. So again, there's about 30 patients that we have this kind of data on at this point in time. 60% of them are females. Average age is about 50, 51. Average BMI about 47. Average weight about 302 pounds. You can see also the comorbidities that they have. 43% of them have diabetes, 70% have hypertension, 66% have sleep apnea, and 53% have heart disease. To kind of summarize the literature, our patients are a little bit sicker, a little bit older, and a little bit more male, all 3 of which would predict higher complication rates. So at 6 to 8 week follow-up, they've lost an average of about 30 to 40 pounds on average, which is a very good weight loss over that 6 to 8 week period of time. And this is where I get really excited. Resolution of comorbid conditions, diabetes, 100% response rate to the surgery, okay? And this is 6 to 8 weeks out from surgery. And let me go ahead and stop here and say this. Most of those patients went home on no medications. In other words, they came into the hospital, they had their surgery, they got up off the operating room table, and they weren't diabetic anymore. And so they go home on no diabetes medications. 10 of those, 77% of those, actually are off all of their medications at this point in time. So they came in on various sundry levels of care, whether it be metformin or insulin or whatever, and now 77% of them have completely resolved their diabetes. 3 of them have improved the situation. So all of them had a response, and you can see the breakdown over there on the right. Hypertension, a 90% response rate. Sleep apnea, an 85% response rate. Again, you can see the breakdown there on the right, and I expect those numbers to even get better with time. Hypertension responds pretty quickly. Sleep apnea very slowly, but I expect that over time, these numbers will get even better with the response rates. And I can't stand in front of a group like this without mentioning diabetes again and jumping up and down on that. Last year at the Heart Summit, I talked about a manuscript that came out in Diabetes Care in 2016. This was endorsed by the American Diabetes Association, and what they wanted to do was sort of realign the algorithm for diabetes care and the treatment plan for diabetes. And what they came up with, and again, this was endorsed by the American Diabetes Association and about 40 to 50 other medical and surgical societies. And what they decided was to start off with the diabetic patient themselves. The impetus for this was the idea that bariatric surgery has such a strong impact on diabetics. Well, let's just do these procedures for diabetics and not just for weight loss. And so they started off with the diabetic, and if their BMI is greater than 40, then they go straight to surgery. So a diabetic with a BMI of greater than 40 goes straight to surgery. That's probably most of your diabetics, right? Okay. Then if you have a diabetic who has a BMI of greater than 35 and they have poor glycemic control, they also go to surgery. So this really changes the way that you treat diabetes and really even the rationale for having surgery, because in the past we were doing surgery for obesity, and one of the fringe benefits for this obesity surgery was the resolution of their diabetes. Well, now we're doing surgery for the diabetes, and one of the fringe benefits of this diabetes surgery is the resolution of the obesity that goes along with that. And again, the American Diabetes Association, they were one of the endorsers of this manuscript, and they came out in their Standards of Medical Care here this year in January, basically again endorsing this and setting this up as their standard of medical care. BMI greater than 40 and diabetic, they go to surgery. BMI of greater than 35 and diabetic and poor glycemic control, they also go to surgery. That's new as of January of this year. So in making a referral, there's our fax number. We tried to make this as easy on you and as easy on the patient as we possibly can. Just send us the patient demographic sheet and their last appointment, and we'll take care of it from there. We will look at the patient. We will look at their insurance and make sure their insurance will cover it. You don't have to worry about the insurance. I don't worry about the insurance. I just let our insurance department manage that themselves because it's so confusing. And so just let us handle that. Let us take that, make us your easy button in that regard, and we'll take care of it from there. And of course, we'll be contacting you about those patients. Now, oftentimes I get talked about, what if I encounter hesitance from the patient? And that's a very fair question. And we do have a lot of things that we can do for them. First of all, you can just send them to us and we can just talk face-to-face. And they may want to do that, they may not want to do that. There's also face-to-face seminars where we go out into the community and we have seminars and we can talk to the patients, and it's a little bit more of a friendly environment, a little less sterile, if you will, and we can just talk to them in a meeting room such as this. We have an online video seminar. It's a 30-minute video. You can't get any easier than that. You sit at your computer, click a button, and you watch a 30-minute video, and it basically goes through our seminar, and so they can even do that if they'd like. We have patient support groups where I won't even be there, and we have our psychologist, Dr. Ermi Johnny, who runs those, and she'll be there with some of our post-op patients. They can talk to some of our patients and just ask questions of people who have been through the process, and that's a very low-threatening environment as well. And the last thing I would mention is to set milestones for these people. What you don't want to do is keep kicking that can down the road. And, 4 or 5 years later, they're still in the same position that they are. So set up milestones for them. Yes, ma'am, your hemoglobin A1C was 9. When you come back in 3 to 6 months, we expect it to be, 8, 7, whatever you think is appropriate. And if not, then we really need to start pushing this a little bit harder. So set up milestones for the patient along the way as well. So one theme that I've been noticing has been coming through a lot of these talks is don't wait too long. Refer early in the process as opposed to later. It's easier to cure a stage 1 cancer versus a stage 4 cancer. And so get us involved earlier in the process and really accentuate that to the patient to get them involved earlier and get us involved earlier. One of the big things that we try to shoot for is getting their BMI below 30. BMI below 30 predicts fewer medications, it predicts fewer diseases, it predicts a better quality of life, it predicts better longevity. And so there's a whole list of reasons why you want to get that BMI below 30. And they did a study came out just about 6 or 8 weeks ago in JAMA, and they looked at almost 30,000 bariatric patients. And one of the things they found, the biggest predictor of a BMI of less than 30 after surgery was what was their preoperative BMI. And if their BMI was less than 40 at the time of surgery, it was highly predictive of success. If a BMI was greater than 50, it was highly predictive of failure. Y'all saw the surgery that I did earlier this morning. That patient had a BMI of 38, and she was diabetic. And it's actually not this patient right here, but this is another example of a patient with a BMI of 38 and diabetes. These are not huge people. These are not people that you would traditionally be thinking of, but these are the people that we can do the most good for over the short term and over the long term. We can help out even the larger people, but we can really do a lot of good for a person like this. So again, I want to thank you for the opportunity to speak. I want to thank you for trusting us with your patients and for your referrals. If there's anything that we can do, we'd be happy to do that. Now I'd like to show a quick 4-minute video, and before that comes on, again, remember these people are only about 3-4 months into their whole journey, but already they're seeing tremendous weight loss, 70, 80, some of them over 100-pound weight loss just in the 3 or 4 months since surgery. We also have seen that they have better health, fewer medications, and just very important to me is a very, very high quality of life after this. So go ahead and roll the video, please.
I pretty much sat in the recliner when I got off work, and it was getting to the point where I was having a hard time doing my job because my feet and my ankles were hurting all the time. My hip was hurting a lot.
It worried me. It scared me that I was becoming my mom. I love her very much. Don't take that the wrong way. She's my best friend. But, I didn't want to be her. I didn't want to have the diabetes. I didn't want to have the heart disease. I didn't want to have a bypass.
The last time I flew, I got my feelings hurt. And I was really struggling to get that seatbelt to click. And I had to end up asking for an extension. And there was a man sitting by me that actually asked to move, and that really hurt my feelings.
It's been probably the most life-changing experience I've ever had, because I've been overweight my entire life ever since I was a small child.
The one event that sticks out in my mind that made me really start considering it was I went to Universal for the first time, and I love theme parks and roller coasters and all that, and was standing in line for a roller coaster. A guy working there came and approached me and my friend and said, I'm going to have to ask y'all to step over here and try out the modified seats. And I'm like, what? Like, I didn't even realize this was an option, that they even existed. I was like, it's a roller coaster. Why, why would it not work? So, embarrassment, humiliation all led up to saying, oh man, I've got to get control of this.
Now that I've had the surgery, it's so much easier to walk. I just actually feel lighter. I no longer get short of breath. I can climb stairs now and be comfortable. I no longer take medication for my diabetes nor for blood pressure.
Having those grandkids, I really wanted to see them grow up. I'd like to see them get out of high school, get married, start families of their own. I want to be around for that.
And you look at going out with friends or family differently now. I try not to center all those events around food because there's not as important. There are other things that we can do, whether it's enjoying shopping or going to the park, or there's different things we can do now. I'm still a foodie. I still love food, but it's you just eat less of it.
It's just so fun to go and see that I'm wearing, 2-3 sizes smaller, and I just feel so much better about myself.
Since I've lost this weight, it's just everything. I'm back to doing the things that I enjoy doing. I don't mind being outside, even if it's hot and humid. I've been in the outdoors my entire life, and I have, been in this deer camp for over 20 years. When we're down there cutting shooting lanes and putting up stands and working on stands, before I couldn't have done that. I'd just been give out. It's pretty amazing. I mean, it's like I got my life back. So yeah, it's I don't know. You have to give me a second.
I haven't flown since I had the surgery, but I am looking forward to flying and not having to struggle with that seatbelt.
It is honestly the easiest surgery that I've ever had, and I've had multiple, unfortunately. The recovery time, I probably was okay to go back to work after a week, just 5 days, but I went ahead and took 7 anyway.
It has been the most life-changing experience. If you have any doubts about where you're headed and what you're facing, then you need to look into it, find out which one's for you, and get it done.
Well, that gets me excited. I appreciate, again, y'all's trust in us and in our program, and thank you again for your time.